All right, good morning, everyone. Hopefully everybody can see the screen. Welcome and thank you for joining us. My name is Linda Herman. I am the Client Relations Manager at Imaging Biometrics. Today's webinar is titled Clinical Advances of Perfusion MRI in the Current Neuro-oncology Landscape. It is presented by Dr. Michael Ive, who is the Director of Brain Tumor Imaging at Stanford Brain Tumor Center. We appreciate you all being here today, and we'll have sometime after the presentation, if everyone can use the Q&A on your screen to ask questions, we'll make sure your questions are answered. And then I also want to make sure everybody knows we will have our next webinar on September 19th. It will be presented by our senior software engineer, Josh McCormick. And the title of his presentation will be Integrating IB Clinic and Routine Clinical Workflows. So again, thank you, Dr. Ive, and I'll just turn it over to you.
Thanks, Linda. And before I begin, just because I can only see my PowerPoint, you can hear and see my PowerPoint. Is that correct? You can hear me and see my PowerPoint?
Yes.
Perfect. Okay. Well, thanks, Linda, for the kind introduction, and for Michael Schmanda for inviting me to give this talk. I've known Michael and Tim and et cetera for a while now, so nice to be on the other end here. Having said that, today we're going to discuss the advances of perfusion MRI in the current neuro-oncology landscape. And during today's talk, we'll firstly review the clinical and imaging landscapes in neuro-oncology. Secondly, we'll highlight the clinical utility of a quantitative perfusion imaging pipeline for assessing brain tumor response to therapy. And I tend to talk a lot, but hopefully we'll have time at the end of this talk to review some interesting cases and have some discussion about these cases and potential techniques. Okay, so let's take a time travel back to the past, back in 2007, when the WHO classification and grading of brain tumors was largely based on what the neuropathologists saw see underneath the microscope. So they look at brain tissue samples and they look for things such as nuclear atypia, Ki-67 proliferation index, mitotic figures, the presence of necrosis and microvascular proliferation, and then they can make a diagnosis of a brain tumor and grade it. And for example, like a GBM, if you have presence of pseudopalissading necrosis, etc. Now, let's fast forward to 2016 when we've discovered a lot about the genetics of a tumor, and we've shown studies that the genetics of a tumor tends to predict its prognosis and behavior more so than what the neuropathologists see under the microscope. So the big lesson from this era is that the molecular genotype, the genetic signature of a tumor, tends to trump the histologic phenotype, what the neuropathologist sees under the microscope. That's not saying that histologic phenotype isn't important, but now we know, again, the genetic signature of a tumor tends to predict its behavior more so than what we see under the microscope. And fast forward to today's time when there's been further refinement and trying to group tumors with similar genetic features as well as prognosis. So in the past, we used to have tumors such as astrocytoma and GBM, but now we're trying to group the tumors based on their genetic features. And for example, instead of just astrocytoma, we have an IDH mutant astrocytoma. And instead of just a GBM, we have an IDH wild type GBM. Now, what's the difference? Well, while the prognosis of an IDH mutant astrocytoma is bad, anything with an IDH wild type, meaning there's an absence of the mutation. For example, in a GBM, the prognosis is worse. And taking that into consideration, again, when we look under the microscope, you can make the diagnosis of a GBM if you have the presence of microvascular proliferation or necrosis. But again, if we just look at the genetic signature of a GBM or of a tumor and it has these kind of mutations, then we can still make the diagnosis of a GBM, and that's the molecular GBM. The same thing with these IDH mutant astrocytomas, you can grade it, but the prognosis is worse if it has a certain signature. And in this case, if there's the presence of a CDKN2AB homozygous deleted gene. So when you have the presence of that homozygous deleted genes, then your prognosis is worse because they respond to chemoradiation less. Now, this is a fairly complex diagram of a GBM, and there are so many different things involved. For example, there are tumor cells, there are stem cells, there's macrophages and microglia, some extracellular matrices, T cells, blood vessels, everything that you can think of, you can name it. And there's been a lot of research effort into imaging each component of this tumor microenvironment to tell us about tumor behavior and tumor prognosis. So a lot of that's under research, but what we have really good clinical and research experience with thus far is imaging blood vessels as a marker of angiogenesis and neovascularities in tumor. So how do we do that? We can do that with a wide array of MR perfusion techniques. There are non-contrast techniques such as arterial spin labeling, and there are contrast-enhanced techniques such as dynamic susceptibility contrast and dynamic contrast enhancement. And everyone is most familiar with what we're going to speak today about is dynamic susceptibility contrast. And that's because for the most part, DCE hasn't really been clinically validated and hasn't really been studied as much as DSC. But no matter which perfusion technique that you choose, there are specific metrics that we can look for when trying to interrogate tumor physiology and hemodynamics. For example, we can look for cerebral blood flow, whether you acquire it with ASL or DSC, and that's a pretty straightforward marker of blood flow. Cerebral blood volume, which is the most widely studied metric in brain tumor imaging, tells us about microvessel area and density, collaterals, and flow. Fractional tumor burden, which is a relatively newer metric, is essentially defined as the volume fraction of contrast enhancing voxels above or below a set threshold CBV. So you're using a CBV to set as a threshold, and then whether you have CBV above or below that threshold, you can kind of map areas of vascularity within the tumor. And this is helpful because it is superimposed on 3D imaging for mapping out spatial areas of vascularity within a contrast enhancing lesion. And we can go over some interesting cases with regards to that later on this talk. And the last metric that I want to talk about is percentage signal recovery, or really just looking at that tail end of the perfusion curve of the signal intensity time curve. And that tells us a lot about capillary permeability, and that's most helpful when a patient presents with a new mass and you're trying to decide what that mass is. Is it a glioblastoma, is it lymphoma, or is it metastasis? So that's more helpful in the pre-treatment setting, at least from our experience. So at Stanford, we have a couple of different protocols, and one is the glioma radiation necrosis protocol, which has a combination of 2D and 3D sequences, which are BTIP compliant. And the BTIP is just the brain tumor imaging protocol and clinical trials led by Dr. Ben Ellingson at UCLA. It's just that it's helpful at multi-center studies to have standardized parameters that people can evaluate over time. But what's most notable about the glioma radiation necrosis protocol is that we optimize it for looking for acquiring accurate CBV measurements. And in this particular case, we use a preload dose to help correct for contrast leakage, and we use a low flip angle to help reduce the T1 effect. So we want to reduce the T1 confounding effects and the contrast leakage to maximize our CBV measurements as much as possible. And in this particular case, we use a half dose scheme. But what are some recommendations? Well, Dr. Boxerman et al. And his team wrote this paper about the consensus recommendations of a dynamic susceptibility contrast protocol for use in high-grade gliomas, and they found that a full dose scheme provided the highest CNR. But and that essentially means a full dose of preload before you give another dose for the actual dynamic images. But if you don't want to use a preload, you can choose not to use a preload and give a full dose for the dynamic images, but use a lower FA values. And both of these schemes have proven to be accurate in assessing CBV measurements. Again, for our purposes, we use a half dose scheme. So while there's a moderate reduction in the accuracy, I think from our experience at least, it's when you longitudinally follow these patients over time with a consistent protocol, the actual number doesn't matter as much as what the trend is over time. And then when the patient presents with a new brain mass, so it's not a known glioma, and the question is not yet, is this treatment effective or is this tumor, we like to optimize our perfusion protocol for looking at percentage signal recovery. And here we want to exploit the T1 signal and not so much mitigate it, because as you can see in these different examples of metastasis, glioblastoma, and lymphoma, the signal intensity recovery at the tail end of the curve is different. For Mets, it tends to be lower. For glioblastoma, it's in the middle. And for lymphoma, there's an overshoot of the baseline that's related to the T1 effects overwhelming the T2 and the T2 star effect. So we kind of have these different perfusion optimization for a specific question at hand. Okay, so let's get on to the pertinent questions in brain tumor imaging. Can MRI features predict histology in WHO grade? And the quick and dirty answer is yes, we can do a pretty good job of that. And these are typical features of a low-grade glioma. In this case, is an astrocytoma WHO grade 2. They tend to be T2 bright, cortical, smaller, not that much mass effect. When we look at ADC, there's high ADC, suggesting that the tumor is not that cellular. For the most part, in this particular case, there's no enhancement. There could be minimal enhancement, and perfusion is generally low to normal. In contrast, the typical features of a higher grade glioma, in this case, it's a GBM. It tends to be larger. There's more mass effect. There's cellularity on ADC with reduced diffusion. There's blood products, heterogeneous enhancement, necrosis, high blood flow, high blood volume, all basically in the contrast of what I showed with a low-grade tumor. So the more features that you have, like what I showed here, the more confident that you're dealing with a high-grade glioma. So again, we're not really looking for 1 or 2 or 3 features. We're really looking at how many features of what is listed here is demonstrated by the tumor. So the more features you have, the more confident that you are dealing with a high-grade glioma versus a low-grade. Of course, there's some overlap, but this is a good general guideline to go by. The exception is in oligodendrogliomas, because high perfusion in oligodendrogliomas relates to fine intratumoral capillaries and does not always indicate aggressive tumors, as you can see in this case of a right frontal tumor. There's not that much mass effect. It's infiltrative T2 signal, no enhancement, but it has really high perfusion on ASL. But this one turned out to be a grade 2. But I'll show you a case where perfusion can be helpful in the setting of an oligo. And this is that case. So the original tumor in this right temporal lobe was resected or biopsy, and this turned out to be an oligodendroglioma grade 2. 8 years later, the patient represented, and we can see that there's increasing T2 signal around the resection cavity. There's no enhancement and there's no perfusion. So while there was increasing T2 signal, we opted to follow the patient over time. The patient represented 12 years later after the initial MRI, and you can see on T2 flare that there's increasing signal intensity around the resection cavity. There's increasing enhancement. And on perfusion imaging, there's increased CBF as well as CBV. So that was a little bit concerning. This was resected, and the histopathology was proven to be a grade 3 oligo. So the teaching point in this case is that increasing perfusion over time can indicate malignant or higher grade transformation. And so often for these tumors, that's why if you're going to use perfusion imaging, it's helpful to have a baseline perfusion to see what the original tumor looks like. Now, with the age of molecular and genetic interrogation, the next relevant question to answer is, can MRI features predict molecular status? The short and dirty answer to that is no, we don't do a good job right now. There's a lot of machine learning and the AI algorithms which can help to predict mutation status, but often those are institutional based, and it hasn't really been commercialized, so it's really difficult to use. But what we have found in clinical practice is that one specific sign has been helpful to identify an IDH mutation in astrocytomas, and that is called the T2 flare mismatch sign, as what is shown here. So what is the T2 flare mismatch sign? It's essentially when you have T2 bright signal on the T2 weighted image, and on the flare image, there's suppression of the majority of the central aspect of the tumor. There can be a little rim of T2 flare hyperintensity, but again, most of the central aspect of the tumor is suppressed. And in the setting of an astrocytoma, this is not relevant to oligos, but an astrocytoma astrocytoma, that's predictive of an IDH mutated tumor. And you can see in the absence of the T2 flare mismatch sign, where you don't have the suppression on flare, this one turned out to be a wild type, or it has the absence of the mutation. So what is the T2 flare mismatch sign? What is responsible for that? When we look at histopathologic studies, we can see that areas of T2 flare mismatch tend to have microcysts, which makes a lot of sense with the MRI findings, right? Because usually cysts, T2 bright, it suppresses on flare. Now, the absence of the T2 flare mismatch sign, you don't really see the microcysts. Now, this sign is highly specific, but not very sensitive, being that if you have the T2 flare mismatch sign, your likelihood of being an IDH mutant astrocytoma is going to be much higher. But if you don't have that sign, that doesn't necessarily mean you're going to be an IDH mutant tumor. You could either be IDH mutant or IDH wild type. So that's essentially how I interpret that. Now, why is that important? Again, we talked about the IDH sign before. Essentially, if you take a group of these tumors, whether they're low grade or high grade, and look for the IDH mutation, IDH mutant tumors, they survive longer than IDH wild type tumors. And that's because when you have the mutation, it portends a better prognosis and predicts a higher rate of response to chemoradiation. That's why that's been important and integrated into the WHO classification system. So let's look at a few examples of that. These are all going to be grade 3 astrocytomas. So this patient presents with a right frontal tumor. It's T2 bright. Centrally, there's flare suppression. You can see it's darker, and there's no enhancement. So this is suggestive of an IDH mutant tumor based on imaging. And that's what it proved to be on after surgical resection. And 3 years later, the patient represented, and you can see that this is just expected post-surgical change, and the patient is doing well. This is another grade 3 astrocytoma. So on T2 weighted imaging, you can just see this infiltrative signal kind of in the right frontal operculum. There's no suppression on flare, and there's no enhancement. So the absence of the T2 flare mismatch sign, you're concerned that it could be an IDH wild type tumor. After a biopsy, that's what it turned out to be, an IDH wild type astrocytoma WHO grade 3. The patient represented a year and a half to 2 years later, and we can see that there's evidence of a prior biopsy site, but now there's increasing enhancement elsewhere within the area of the originally non-enhancing tumor. And this was re-biopsied and resampled, and this turned out to be a GBM IDH wild type tumor. The patient represented less than a year later, and you can see that the tumor has really progressed, that there's increased enhancement and now increased perfusion. So the prognosis in this patient was poor. This is another example of a grade 3 astrocytoma. If we look at this tumor in the right temporal lobe, it's bright on T2. There's a lot of flare suppression, but centrally it's a little bright, so it's kind of mixed. Is this a T2 flare mismatch sign? Kind of hard to know. Nonetheless, after surgical resection, this proved to be an IDH mutant tumor. So the patient went down the standard treatment course and had chemoradiation, and at some point had Avastin. The patient represented 3 years later. What's happening? Well, there's been a lot of progression of T2 flare signal, even across the corpus callosum, that you can appreciate better on the flare. And there's areas of contrast enhancement. But this is an IDH mutant tumor. What's going on? As I mentioned before, in these higher grade astrocytomas, the IDH mutation does not tell the entire story. What we're looking for is CDKN2AB homozygous deletions, which this patient unfortunately had. So when we take IDH mutant tumors across all tumors and grades as a group, we can see that grade matters because, again, the grade 2, they have a better survival than the grade 4. But when we look at CDKN2A homozygous deletions, those with the deletions, whether they're lower or higher grade, tend to do worse. Their overall survival is worse. So again, this is just an example of genetic features. We're learning about the molecular signatures of tumor playing a really big part of how they behave over time and what the prognosis of the patient is. Okay, so let's skip forward from the pre-treatment setting to the post-treatment setting, where it's a lot more complex because now, remember that diagram, in addition to all of that, now we're trying to differentiate, is this dead or treated tumors or is this viable tumors? And usually standard gadolinium enhanced MRI is a little bit difficult to interpret. And that's oftentimes because it's non-specific, and we'll get to that in a little bit. But before we get there, let's talk about the standard timeline of treatment in a patient with a GBM. So a patient presents to the hospital with a mass suspicious for GBM. They get surgery. Then we get immediate post-op MRI, and that's basically to look for any residual enhancement, because any persistent enhancement within the resection bed within the first 2 to 4 days after surgery is concerning for residual tumor. After that, the patient gets the standard chemoradiation therapy, and these days and age, it's the STUP protocol. And then their first post-treatment MRI is approximately 3 months after surgery, and depending on which institution the patient is, they get a repeat MRI every 2 to 3 months thereafter, essentially for the rest of their life. And at Stanford, we do it every 2 months. And based on these subsequent MRIs, then we're deciding how to best treat the patient with TTF, tumor treating fields with chemotherapy such as CCNU, with anti-angiogenic therapy, or placing the patient into clinical trials. And this is just to say that because the patient is getting consistent serial imaging every 2 to 3 months, I think it's important to leverage that and include a consistent protocol, for example, perfusion protocol, each time point, because you can see that changes will within the brain tumor microenvironment happen pretty quickly. So it's important to catch that as much as you can. And that has benefits over than just, for example, imaging a patient at one time point with like PET or something, and then going based on that, right? Because oftentimes these changes happen really quickly. You really need to capture it on a more consistent early time basis. So this is the dilemma with what we're facing. These are 2 separate patients with GBM who had surgery and chemoradiation and represented. And the question often is this tumor or is this treatment effect? So if you had to guess if the patient on the left had tumor or treatment effect, what would you guess? How about the patient on the right? If you were to ask me, I'd be like 50%. I have no idea. I couldn't be able to tell you very much. And in clinical trials, we assess tumor response to therapy by the response assessment in neuro-oncology criteria, which primarily looks at T2 flare visual evaluation as well as bidirectional measurements of contrast enhancement. And as I previously mentioned, gadolinium is a little bit non-specific because it crosses any area where there's blood-brain barrier disruption. You'll have that in both radiation necrosis as well as tumor, but a standardized criteria is necessary when you're looking at clinical endpoints. And the last webinar, I believe, Dr. Shmanda talked about delta T1, or essentially contrast enhancing volume as a clinical endpoint, which is great. We kind of need that. But on a day-to-day basis, especially with me being a clinical neuroradiologist, how does that what can we do to help us make a decision at a single time point? And perfusion imaging has been helpful in that respect. Now, the concept of perfusion imaging in this post-treatment setting is that contrast-enhancing lesion with low perfusion, whether it's low CBF or low CBV, it tends to be treatment effect. In contrast, a contrast-enhancing lesion that tends to have high CBF or high CBV, that tends to be recurrent tumor. So going back to these 2 examples, if I was to overlay a perfusion map, in this case, it's a fractional tumor burden map where red voxels tend to indicate higher perfusion, blue voxels tend to indicate lower perfusion. We can see that the image on the left was more suggestive of tumor. And this was actually proven on histopathology. Both patients had surgical resection, and the patient on the left had tumor, and the patient on the right had treatment effect. And that was hard just to determine based on the GAD enhanced MRI. So let's talk about what the map represents. And this is fractional tumor burden. And just really briefly, it represents the volume fraction of contrast enhancing voxels above or below a set CBV. Again, you set that CBV. Anything above it, you color it different voxels. Anything below it, you color it different voxels. So you have an idea of what different areas of the contrast enhancing volume look like. So how do we get this? Well, we essentially get the delta T1 difference map between the pre-GAD and the post-GAD. Once we have the contrast enhancing volume, we superimpose that on the DSC perfusion images, and you can obtain the FTB map. And that's kind of a simplified concept of what is happening here. Now, which thresholds are we using? Well, we set to use 2 different thresholds, and the use of 2 thresholds really builds in a gray window, which is this yellow area, this indeterminate area where you're not quite sure what's happening because there's overlap. Now, the thresholds we decided to test out were thresholds that were studied in the literature. So many histopathologic studies with imaging, localized guidance showed that a threshold of 1.0, anything was able to differentiate between treatment effect and tumor. So essentially, anything with a blood value greater than 1 was most likely to indicate tumor. But we wanted to test a second threshold. And when we looked at what threshold was indicative of aggressive tumor, we saw a threshold of 1.7, a normalized threshold of 1.75. So we wanted to test out both of these thresholds. So any value less than 1, we were that was suggestive of something that was treatment effect or hypovascular tumor. Anything with value of greater, and then we colored that blue. Anything with any voxel with a value greater than 1.75, we colored that red, and we were thinking, well, that's probably going to be aggressive tumor. And any value between 1 and 1.75, we thought it was a little bit indeterminate. It could be treatment effect, it could be tumor, it could be admixture. We don't quite know what's going on. So in this study of 44 suspected recurrent GBM, so they had worsening contrast enhancement on a follow-up MRI. We looked at this, and in general, we saw that treatment effect tended to have low blood volume and low fractional tumor burden based on our thresholds, and tumor tended to have high blood volume and high fractional tumor burden based on our thresholds. And again, for ease of interpretation and clarity of interpretation, the low blood volume areas were colored blue, the high blood volume areas were colored red. And you can do different processes in terms of evaluation of CBV and FTB. Oftentimes we do normalization, which we normalize a tumor to the contralateral white matter that's normal. But there's also standardized FTB, which is essentially a transformation of RCBV intensities to a standard scale, which eliminates the process of having to manually normalize it to the contralateral white matter. When we looked at the performance of the 3 different fractional tumor burden categories and CBV, we saw that FTB high, the red voxels, as well as CBV performed the best to differentiate between treatment effect and tumor. And we didn't publish on this, but we also compare that to a standardized approach. And we used 2 different thresholds, 1.75 and 1.56, which was previously used as well. And in our experience, we found very similar area under the curve and performance, essentially. So normalized and standardized approaches were pretty similar in terms of the ability to differentiate between treatment effect and tumor. It's just that, again, with standardized, you don't necessarily have to normalize it to the contralateral white matter. So we wanted to implement this at Stanford, where we got 3D volumes and measurements of perfusion, and we can track it over time. And we also implemented a brain tumor reporting and data system scoring into a report to help clarify our interpretation. And this is known as BT-RADS. And this is very similar to everything else in radiology where there's a RADS, like BI-RADS in mammography, LI-RADS, TI-RADS. There's so many different RADS. But essentially, and very briefly, there's a score of 0 to 4. 0 is baseline. 1 is your improvement in imaging findings. 2 is no change. 3 is worsening imaging findings. 4 is essentially the same, where it's worsening imaging findings, you're suspecting tumor. But where it gets a little bit dicey is in this 3 category when you have worsening imaging findings, and it can be due to treatment effect. it could be due to tumor progression, or it could be due to an admixture of both, or you just don't know. And we have found that the use of FTB really fits nicely and helps us to define what we're looking at. Whereas if you have a lesion that's predominantly blue voxels, it tends to be treatment effect. If it's predominantly red voxels, it tends to be tumor progression. If it's yellow or a mix of blue and red, then you can have admixture or just you don't quite know what's going on. And that's really the uncertainty that's built into our interpretation, which is nice because obviously medicine, and which includes radiology, is not black and white. Okay, so the question is, when we do perfusion imaging, is it adding value? Is it changing day-to-day management? So we wanted to look at this on a more systematic level here. So this is a retrospective study of 44 patients with suspected recurrent GBM who had histopathology and surgical resection. Now, of these 44 patients, 28 patients had tumor on pathology and 16 patients had treatment effect on pathology. So not all of these were tumors. And then we got a consensus panel of 5 physician raters together, 3 neuro-oncologists, 1 radiation oncologist, 1 neuroradiologist. And we asked that consensus panel to look at the imaging, which included FTB. And then so after their scoring, we compared it to what we saw on path. And you can see in the group with tumor on histopathology, there was an agreement between the imaging and the path in the vast majority of cases, and the same proved to be true for the treatment effect, although it's a little bit less because that makes a lot of sense because treatment effect is a little bit more difficult to interpret. And then we decided to see if that would affect surgical or medical management. So here we asked the consensus panel based on the imaging, again, which included FTB, if they would change surgical or medical management. And then we compared that decision to what actually occurred in real life. And that decision that occurred in real life was based on the histopathology, obviously. And as you can see in the group with tumor on pathology, the imaging agreed with the decision that was made. The decision based from the imaging was agreed with the decision based from histopathology in the vast majority of cases. Again, a little bit less so on treatment effect. But again, it's a little bit difficult to ask that question because when you have treatment effect on histopathology, sometimes it's hard to know what your decision is going to be. So that makes a little bit more sense. But for the most part, we showed that imaging, including FTB and perfusion imaging, it helps with diagnosis and it helps with influencing and informing clinical decision making. Next, so that was on the clinician side. Next, we wanted to see if it would affect how neuroradiologists interpret post-treatment HCG surveillance imaging. So we just looked at 50 patients who presented for routine surveillance imaging. We got a group together of 4 different neuroradiologists, and we had them look at 4 sets of images with just GAD MRI alone, with GAD and ASL, with GAD and blood volume, CBV, and with GAD and FTB. And then we asked them to interpret the images using the BT-RAD scale. And essentially what we found, and when we compared the inter-rater agreement, we found that the highest agreement occurred in the group that was interpreting GAD MRI with FTB. And then, so in terms of BT-RADs, again, remember I mentioned, usually that 3 score is a little bit dicey because you can have worsening imaging findings related to treatment effect, related to an admixture, related to progression. So we compared whether or not the scores were upgraded or downgraded with the addition of perfusion imaging across the raters. And for each raters, you can see that's on the x-axis. On the y-axis is the number of score changes. With the addition of perfusion imaging, whether it's ASL, CBV, or FTB, there were differences in the score changes. And the greatest number of score changes was observed with FTB. So that's pretty significant, right? Because you would interpret it one way with GAD MRI. When you have perfusion, you're going to be interpreting it in a different way. And then close to final, but we also looked at rater confidence in MRI interpretation. So how does the addition of perfusion imaging affect a rater's confidence in image interpretation. So we asked each rater to score on a Likert-based score from 1 to 5, 1 being not confident, 5 being very confident. And as you can see, for each rater, the greatest confidence in MRI interpretation was from GAD MRI with FTB. And of course, not surprising, the lowest confidence was with just pure GAD MRI. And this final part of the study, we compared each rater with a consensus score. And obviously, you always need like a reference standard in the study. Usually we like to use histopathology as a reference standard, but that, oftentimes patients don't get surgical resection for a single time point MRI after post-treatment. But the consensus standard in this score was based on a neuroradiologist and neuro-oncologist who routinely attend tumor board. So when we compared each rater with the consensus score, you can see that the agreement was the highest with GAD MRI and FTB. And this just shows that the use of FTB imaging in post-treatment high-grade glioma surveillance imaging tends to be helpful, at least for the neuroradiologist clinical interpretation of it. And based on our results in high-grade gliomas, we've started to translate our results to patients with brain metastases previously treated with stereotactic radiosurgery. And again, very similar to the HGG studies, we showed that FTB high and relative cerebral blood volume tend to differentiate between treatment effect and tumor the best. And the numbers are a little bit lower than the GBM studies, just probably because we have a smaller sample size, and Mets in general, they tend to be a more heterogeneous group. So it's really future studies, we really need to stratify these Mets according to the histology, because all Mets look and behave differently, and just see if these metrics hold. Okay, so let's see, where are we at with time? We have a little bit of time. So let's go over some interesting cases. This is a 66-year-old female with altered mental status who presented with these images. On FLAIR images, there's an area of T2 bright signal, kind of in the left caudate region. On diffusion, on ADC, you can see there's low ADC, suggesting cellularity. There's enhancement of that area on T1 post-GAD. And there's no obvious high blood volume. So if you're thinking of a tumor, yeah, this could be lymphoma. But what we noticed was also there's T2 flare signal that was discontiguous and not connected to the area that was contrast enhancing. So we weren't sure, like, could this be lymphoma? Could this be a weird glioma? We weren't entirely sure. So our surgeon wanted definitive diagnosis and our clinicians wanted definitive diagnosis. So we underwent sampling of that contrast enhancing lesion. That ultimately turned out to be lymphoma. So interestingly, when we looked at the time signal intensity curve of that lesion, it showed this white curve here. And this tail end of the curve, you can see there's overshooting of the baseline, again, where the T1 effects kind of overwhelms the T2 star effects. And that curve was characteristic of lymphoma, which that was in that particular case. So I thought that was kind of a very cool case. We still have to follow to see what the T2 flare signal in the frontal lobe that was discontiguous from this lesion was, but this one ultimately turned out to be lymphoma. And again, this is just a review that the signal intensity time curve and the percentage signal recovery looks different for Mets, GBM, and lymphoma. And that's related to the T1 effect overwhelming the T2 star effects. And if you wanted to get an optimized PSR protocol, you don't want to use preloading when you use high FA. This is another example of a 35-year-old male with GBM. You can see that in the right temporal lobe, contrast-enhancing lesion. There's high blood volume. Okay, the imaging is consistent with the GBM. The patient underwent surgical resection and had chemoradiation, and represented 3 years later. And you can see there's 2 contrast-enhancing lesions at the site of the original tumor. See, on CBV, it's a little bit hard to know what's going on there, but you can see that the anterior lesion did not have high blood volume. The posterior lesion did. When we perform fractional tumor burden, you can see that the anterior lesion had predominantly blue voxels, and the posterior lesion had predominantly red voxels. Okay, again, so we're predicting more likely to be treatment effect anteriorly, more likely to be tumor posteriorly. This is during the time when we were trying to validate the FTB imaging. So our surgeon resected both areas, and on histopathology, that's what we essentially found, that the anterior lesion turned out to be treatment necrosis and the posterior lesion was GBM. And this is a really cool case. This is a 59-year-old male with GBM. And you can see the GBM in the right temporal lobe. It was associated with high perfusion. After surgical resection, most of that was resected. And this patient had a complicated course afterwards. He had chemoradiation, he had a recurrence that was, again, surgically resected, then he was re-challenged with TMZ, and then had chemotherapy, and then finally presented 3 years later. And there's this new contrast-enhancing lesion along the posterior aspect of the resection cavity. So, of course, when you look at this, you're going to be like, that looks like tumor. So we thought that that was tumor. And then the plan at this time was to undergo stereotactic radiosurgery. And you can see all the different radiation fields. The lesion within the red has the highest dose, of course. Within the dark blue, it's the lowest dose. But you can see that this lesion is within the radiation field. And then the patient represented 3 months later after CyberKnife treatment, and the contrast-enhancing lesion got bigger. It's a little bit heterogeneous. What to make of that? Could that be treatment effect? Could that be progressive tumor? It's a little hard to know based on GAD MRI, but we do notice that there's some contrast enhancement anteriorly, which kind of looks like tumor. So I think most people interpreting this MRI, they would be like, oh, this is probably just all tumor progression. The patient presented 9 months later, and we can see that the area that was previously treated no longer has enhancement. So in fact, that was treatment effect. But anteriorly, there's progressive enhancement, as well as some areas of enhancement along the posterior aspect of that previously treated lesion. So this really looks like tumor progression in addition to what was a treated lesion earlier on. So the patient received fractionated radiotherapy and represented with this image 3 months later. And you can see that anterior lesion kind of has heterogeneous enhancement, but we do see new areas of contrast enhancement around the previously treated lesion. So what's going on? Again, a little hard to know, but one would probably think that this is all tumor progression. So let's see how the addition of perfusion imaging can be helpful in this particular case. Okay, so I'm going to show you the fractional tumor burden map, predominantly red voxels. So looks like tumor. So this was CyberKnifed, underwent stereotactic radiosurgery, and we noticed that the perfusion of that lesion decreased. So in fact, this was predictive of treatment effect. And all of that progressive contrast enhancement anteriorly outside of the radiation field showed high fractional tumor burden. So that was consistent with tumor progression. And after the patient presented 9 months later, what's happening? Well, again, the area that was previously treated no longer enhances, does not have perfusion, but everything else kind of has really high fractional tumor burden. So that was consistent or suggestive of tumor progression. After fractionated radiotherapy, what's happening? Well, the anterior lesion showed low fractional tumor burden consistent with treatment effect, but everything else showed high fractional tumor burden consistent with tumor progression. And this is how the addition of perfusion imaging can help you to differentiate what's going on within the tumor, because not everything may be acting the same way, especially when you have areas of when you have different areas that are treated versus other areas. And while I really love perfusion, it's not the be-all, end-all, and this is a classic example of that. This is a 71-year-old female with GBM. We see this enhancing lesion in the left posterior brain. It has really high perfusion, high CBF, high CBV on ASL and DSC. 10 months later, after surgical resection and chemoradiation as well as Optune, we see the patient represent with a worsening area of contrast enhancement at the site of the original tumor. But what do we notice across all perfusion modalities, ASL, DSC, and DCE? It has low perfusion. So this is not artifact. This is, in fact, low perfusion, low CBF, low CBV, low fractional tumor burden, low K-trans. So I actually thought that this was going to be treatment effect, but we underwent surgery anyways, just to see if the patient qualified for clinical trials. And what we found was under the microscope that in fact there was a lot of tumor in this sample that we thought was going to be treatment effect. So then I was like, oh, what's going on here? Let's ask our neuropathologist. And then when our neuropathologist looked at the tissue under the microscope, he didn't find that many vessels compared to the original sample when there were a lot of vessels. So there has been some modulation of the vessels related to the treatment. And this is just to say that, again, perfusion is not be all end all. It's a good guideline to tell you what's going on. And it's a good marker, but it's not always 100% correlated and tied in with tumor proliferation. And that's why there's still ongoing efforts to look at other techniques such as CEST or even PET-MR with amino acid tracers. So thank you for your attention. I'm happy to take any questions. You know, if we don't have time to do that, you can feel free to email me as well.
While we wait, Dr. Ive, I do have a question. Do you find that your surgeons are using the maps for navigation?
For sampling purposes, yeah. So if they were just going to go sample and find an area which would yield the highest which would have the highest diagnostic yield, then they would look at the perfusion map beforehand, and then that would guide them in their surgery. But oftentimes that's not the goal of surgery. In the post-treatment setting, it's more of just getting tissue in general for determination of clinical trial purposes and things like that. But I have to say, before we implemented the perfusion pipeline and afterwards, they were skeptical in the very beginning, but now everybody has bought into seeing the added information that it yields compared to just GAD MRI alone. And I have to say, like GAD MRI, it's very useful. But again, you know, for assessing clinical trial endpoints, it's a little different than what we do on a clinical daily basis when we're trying to make a decision on a patient's single time point MRI.
Very good. Okay, we have a couple questions here. The first one, do you perform most of your studies at 3T or 1.5T?
I mean, obviously, definitely 3T, but that's not technically possible. Some of our cases are performed at 1.5T. But again, there hasn't really been a dramatic difference between 1.5T and 3T in terms of the perfusion results that we get. So we love 3T, but I mean, realistically, you know, you can't be a chooser.
Understandable. Okay, Dr. Kathleen Schminda asks, excellent talk. Thank you for this last example. Do you have spatially localized tissue samples to match with the imaging?
That's a great question, Kathleen. I wish we did. We have some, but it's not performed in some sort of systematic way. And that's actually the next step. We're trying to do a study to do that. It's just been a little harder getting that study off the ground. But from some clinical examples that we do have, there is correlation between our thresholds and what we find on histopathology. But hopefully we'll be able to show that in a more systematic, research-oriented way in the future.
Very good.
And we do have a couple of questions in the chat room. It looks like one here is, does T1 overloading and the perfusion curves depend on the specific GAD agent used, or should it generalize across GAD contrast agents?
Yeah, that's a great question. You know, I haven't really compared all the GAD agents across, compared them to one another. And I would imagine them being very similar, though.
And then one additional question here, a very informative talk. I missed the beginning, but are these maps automatically created and added to your packs?
I wish they were. Yeah, that's the goal, right? To have this pipeline kind of automated so a radiologist or a technologist doesn't have to be involved. And Michael, is that down the pipeline?
It is definitely in the pipeline, yes. And we're getting very close. So as soon as a release candidate is ready, we probably have you be one of the first people to try it out. So
that's awesome. That would be awesome. But currently, right now, our 3D lab at Stanford, they're involved, and we trained a bunch of technologists to help us process the images. And luckily, the way that it's processed, it's not very time consuming, but you still need manual input from somebody doing semi-automated segmentation. So if that becomes built into some sort of automated pipeline, that would save us a lot of time.
Right. And just as an FYI, we do perform some of this as a service for sites where we actually can remote in and actually do the workups themselves if they're overloaded or need some additional expertise. We can provide that as a service. So don't hesitate to reach out to us.
Okay, one more question. What is the PSR protocol? Single dose GAD with what flip angle?
Yeah, single dose GAD with 90 degrees.
90 degrees, okay.
Yeah. I think in contrast for CVV optimized protocol, we use a flip angle of 30 degrees.
Okay, that looks like that's all of our questions. It's right at 10:52. We'll wait just a minute if anybody else has anything else to add. We appreciate you being here today, Dr. I. We appreciate your time on all of this. I want to, let's see, one more question. So single dose 90 degrees and 1/2 and 1/2 with 30 degrees. Is that correct?
That's correct, yeah. PSR optimized former, CBV optimized latter.
Okay, great. All right, well, very good. Our next webinar, again, will be on September 19th with Josh McCormick. He's a senior software engineer for imaging biometrics, and the topic will be integrating IB Clinic and routine clinical workflows. So if nobody else has questions, any more questions, this concludes our webinar. And again, thank you all for joining us today.